the Newark LGBT Community Center, and in honor of Trans Remembrance Week, we are recording tonight a discussion with Dr. Michelle DallaPiazza, who runs the Trans Health Services at the the hospital. What's the proper name for the hospital? Because we're so used to calling it UMDMJ.
Right, yeah.
Is it
So
still UMDMJ?
no, it's University Hospital.
University Hospital.
And the
Okay.
medical school is now Rutgers, New Jersey Medical School.
Right. Okay. So we had a merging of those organizations, and so I'm going to read her bio, brief bio, and then we're going to let Dr. DallaPiazza talk, and we're going to have some questions. So Dr. DallaPiazza has been an HIV primary care provider and patient advocate for over 10 years. She started offering gender affirming care as part of her practice 4 years ago, integrated with HIV treatment, HIV prevention, and primary care. She is passionate about the transformative role that affirming and holistic medical care can provide for transgender patients and communities. And I'd like to introduce to you Dr. DallaPiazza, who can give us a little background on her work and what the clinic and her services are offered at the university. Thank you.
Thank you so much for inviting me, and thank you to the Newark LGBTQ Center as well. As mentioned, I'm Dr. DallaPiazza. My pronouns are she, her, hers, and I am from the infectious diseases practice at University Hospital, part of Rutgers, New Jersey Medical School, as you had mentioned. And through infectious diseases, we had recognized in our practice that there was this vibrant transgender community within Newark and the surrounding areas. And about 4 years ago is when we started opening up some clinical trials focused on HIV prevention, using long-acting injectables and infusions for the prevention of HIV. And part of the target population was transgender folks because of the potentially increased risk of HIV. And in doing numerous community outreach events and focus groups, it became very clear that there were a lot of unmet medical needs for transgender populations. And that really made us take a critical look at what we were doing as a practice for engaging transgender folks into care. And unfortunately, what we found is that we were not being very successful. So we only had a handful of transgender women who were engaged in HIV primary care in our practice. And most were not really retained in care, meaning that they would come for one visit, but kind of not come back, or come for just a few visits. And in addition to that, we had this growing PrEP program, which is HIV prevention, with pre-exposure prophylaxis. And we had no transgender folks enrolled in our PrEP programs. So we started to think about how we could do a better job, because clearly we were missing the mark. And from those focus groups, what was really clear is that transgender folks needed a safe space where they felt where they belonged and were welcome. And one of the huge medical priorities that they had identified was gender affirming hormone care. And so the clinic directors at the time, Randalia DeShields and Dr. Shobha Swaminathan, I was kind of new to the practice. They asked me if this is a project that I was willing to take on, and I really embraced it. As an infectious disease doctor and an HIV primary care doctor, you recognize how important it is to do really meaningful work and outreach into vulnerable communities, and to work with patients who are at greater risk for HIV and really subjected to a lot of the social determinants of health that we worry about. So I went to numerous conferences, and I also talked to colleagues that I had worked with in the past, and I reflected on my own experience, in providing hormones in other settings, for example, for male hypogonadism, which is, cisgender men who have low testosterone. And I recognize that, gender affirming hormone therapy, it's not rocket science, it's medicine and it's evidence-based. And it's really a very important part of holistic care. And so I started incorporating it into the practice. And we just saw an incredible growth within our practice. So we not only were able to engage with transgender women living with HIV, but transgender women who don't have HIV, and also transgender men. And so we went from having only 7 patients in our practice who were not necessarily retained in care, now to having 150 transgender patients in our practice for whom we provide primary care and gender affirming hormones.
And so I used to work at one of the largest HIV clinics in Newark at the Peter Ho Memorial Clinic some years ago. And from my experience, the issues of having access to hormone treatment was a big deal back then. And a lot of people were getting hormones, but they were getting hormones on the street market. They were not getting them from physicians because there weren't a lot of physicians, I think, that had the experience to even deliver it.
Right.
And I think as far as paying for it was an issue. So how is what for the patient with insurance, is the insurance now covers that kind of therapy?
Oh yeah, in fact, in New Jersey, we're pretty fortunate because insurance companies are mandated to cover gender affirming therapies. And then that's really by state mandate from the Department of Health. And so even though some therapy, the full gamut of therapies may not be covered, the most essential therapies generally are. So this includes things like hormones, androgen blockers, and many surgeries as well, though not all surgeries are covered. And to a certain degree, some insurance companies have some discretion about what they will and won't cover with respect to surgery. So the prime example is chest feminization surgery, which is a surgery that a transgender woman may pursue in order to feminize the chest. And that could include implants or reconstruction of the chest. And some insurances cover it as a part of gender affirming therapy. Other insurances view it as more of a cosmetic procedure and will not cover it because you can get breast development with hormone therapy. But it's not exactly the same. I mean, people will have varying degrees of breast development on hormones, and chest feminization is more than just making the chest look larger. It also, there's some reconstructive elements of the chest feminization surgery that really feminizes the shape of the breast as well.
So in your clinic, you have both men and women.
Mhm.
And one of the things you mentioned was the thing about feeling safe. One thing that started the Newark Community Center was an idea of opening up a safe space for LGBTQ people. We opened up a few years after the Sakia gun murder in Newark. And so our main purpose was really to be a safe space because there wasn't one. And so how did you create that safe space within the, confines of the hospital setting?
So that's a really critically important question, and one that is important for any place that really is trying to do the same type of work that we're doing. You cannot do it without first considering your space and your staff and anyone that will be in contact with your patients has to know how to make the space a safe and welcoming place. So that was a big part of our transformation as a clinic. We early on recognized that we couldn't just start offering hormones and everything was going to be happy and everyone would be, oh, we're going to come, we're going to go, right? If a person comes and at the door, the security guard misgenders that person, or someone at the front desk or one of the nurses, or you refer the patient to a service in the hospital like radiology and they're misgendered there, then they're not gonna feel like this is a safe space for them. So one of the things that we did, at least within the confines of our clinic to start, is that we looked at all of our spaces. We made sure that we had gender neutral restrooms. We also took a critical look at all of the things that were hanging on our walls and the type of reading materials that we had in our waiting room, and made sure that they were more inclusive and represented LGBTQ identities across the board. We also, especially through our research program, had arranged for numerous community outreach events and participated in Newark Pride events with tables and sponsoring fashion shows and sort of all types of like really positive and exciting events out in the community. And importantly, we trained everyone in the clinic, and we continuously do training. So just last month, actually, I did an updated training for our staff at our monthly all clinic staff meeting. But we've invited outside speakers to come and do pronoun training and Transgender Health 101 for all of our staff. And we've had t-shirts made for all of our staff. So during Pride Month, we always take a group photo with our t-shirts. So it's really a group effort, and no one can be left behind in this effort. And I've been just so inspired by the staff in our clinic and how much they've rallied around this and been so supportive and really embraced this initiative in a very positive way. And then the other thing that we've done is recognize that, our little bubble of our little clinic within the hospital, the hospital is huge and there's so many different departments and there's so many different moving parts. So we made sure that we partnered with University Hospital, and one of our greatest advocates is actually the chief nursing officer at the hospital, Dr. Curtin. Dr. Curtin came to University Hospital around the same time that I did, maybe a little bit after I did. And he really led initiatives for education across all of the hospital departments. And he was able to put together a task force in order for University Hospital to gain an HEI designation as an LGBTQ friendly hospital. So
Really?
finding those collaborators, those allies, those partners, and teaming up together in order to do this work and to do this education is really critically important.
So are there any trans employees that are part of your clinic?
Yeah.
You don't have to identify them. I'm just
Yeah.
asking if you have actual trans men and women who are working there.
Yeah. So
And them being there, does that help change the culture, make it more, open and friendly, make people more sensitive and aware of the issues that trans people may have when they come into a medical setting?
that's a wonderful point and a critical aspect of any program. And we do have transgender staff in our clinic. And it has changed the atmosphere because our staff work very closely together on behalf of the patients and on advocating for the patients. And many of our transgender staff also participate in events like Transgender Awareness Week at the hospital and in training at different departments in the hospital. So that's a really important component of what we do. And of course, our transgender staff have an interest in serving transgender patients. And so they play a big role in connecting our patients to care and navigating through the healthcare system and really helping with the gender affirmation process.
And so is the clinic open now,
Yes.
daily? And what are the hours of operation there?
So the IDP, the ID practice, is open from 8 to 5 every day, Monday through Friday. Right now, we don't have any weekend hours, but we have two providers primarily that provide gender affirming hormone therapy. It's myself and Dr. Deanna Finkel. And so patients who are looking to make an appointment can call, the IDP and ask for either Dr. DallaPiazza or Dr. Finkel.
So now, if you're not HIV positive person, what are the major health issues that you see in your population in terms of, are the chronic conditions the same? Is it diabetes? Is it, heart disease? Is it, respiratory disease? Is it the same kind of disparities that you see in the general population?
Yeah, I would say that that's probably generally true. And so through our primary care, we have many patients with diabetes, with hypertension, hyperlipidemia, and some with asthma or other respiratory diseases. And it's probably about the same as the general population. Although, generally speaking, within our patient population, we have high rates of all those comorbidities and high rates of tobacco use and substance use disorder. We also have a full service substance use disorder treatment program called Restore, where we offer buprenorphine-based medical assisted therapy for opioid use disorder. And I think the major disparity, though, that does feel a little bit different from the general population that we serve is with mental health issues. And I think I mean, I know that there's been a lot of literature on this. I mean, a lot of that is really triggered by gender dysphoria, the dysphoria that someone may feel as the result of the incongruence between the sex assigned at birth and their experienced gender. And but a lot of it also comes from discrimination and trauma as a result of being discriminated against because of transgender identity. And so we see among our patients that they have significant trauma histories dating back to early childhood. And I think that has a major impact on your mental health and well-being later on in life. Because, we in our particular clinic, we mostly manage adult patients.
Yeah, I
So
was about to ask you, is it mostly adults 18 years and older that you
yeah,
serve?
yeah, 17 and older.
17
There,
and older.
there is a separate clinic that's part of the Division of Adolescent and Young Adult Medicine that does treat adolescents with gender incongruence. And that is primarily through Dr. Bentsianoff, who's a pediatrician and adolescent medicine specialist.
And that's located within the hospital complex as
Yeah,
well?
our clinic is at 140 Bergen in the Ambulatory Care Center. Dr. Bensionov's clinic is in 90 Bergen, which is just across the street.
Across the street, right?
Yeah.
Yeah. Okay, I'm familiar. I'm familiar. And so let's talk a little bit more about the mental health issue. So if I have a mental health issue, you can provide referrals where I'm not going outside to some other place, but everything is kind of right there for me.
Mental health referrals are a major need for us. It's very difficult to find qualified mental health professionals, just generally speaking. But of course, those are also qualified to work with transgender patients and making sure that they understand all of that trauma and on everything else that a transgender patient or a non-binary patient may be experiencing. We have a psychiatrist in our clinic, Dr. Kennedy, but right now she's really tasked with seeing our patients living with HIV. We also have a psychiatry resident that comes to our clinic once every other week, Dr. Baba Jide, and his main interest is in transgender mental health. And so he's been able to provide really excellent care and therapy, counseling, and medical management for a lot of our patients. The other issue with mental health care is that even patients who don't have mental health concerns or mental health diagnoses will still often need to follow with a mental health provider because the insurance requires it in advance of surgery, which is obviously a major barrier. The insurance companies will often require multiple letters from multiple different professionals, and some of them require 2 letters from 2 separate mental health professionals before approving a gender affirming surgery. So
Really?
yeah, so it's
And will the insurance cover those costs?
Mhm.
Since it's required, I guess they have to if you're moving towards surgery and that's one of the
Oh, you mean
requirements.
the cost of the mental health
Yeah, the
referral?
mental health, the psychiatry,
They may or may not, actually. It just depends on whether the mental health professional participates with the insurance
the
company.
insurer.
So if
Okay.
you can find someone that participates with your insurance company, you may have to pay out of pocket for these letters because many mental health professionals don't participate, especially with insurance plans that are managed by Medicaid.
And so there aren't a lot of community resources. If you can't get this service at the hospital, there aren't a lot of practitioners in Newark, Essex County area that do this work or have experience with this work?
Yeah, that also take insurance. Oftentimes we will use Psychology Today, which has like a database of mental health professionals, and you can search by zip code, and you can also search for someone who has expertise in LGBTQ mental health care. And so we will often search for providers that way, and you can, investigate whether they accept insurance, and if so, what kind, and do they take the patient's insurance, and but it's a very complicated process. So we have within the clinic, of course, medical case managers and patient navigators to try to help navigate that complicated process.
Yeah, I was about to ask you, do you have patient navigators? Do you have medical case managers? You have, I guess, social workers,
We do.
substance use counselors. Those are all disciplines within the clinic.
That's right. Mm-hmm.
Okay. And so most of your patient base is, are they African American? Are they Latino? The mix of people? Talk about the ethnicity and the diversity within your patient base.
Yeah, so it's interesting. About 85% of the transgender women or non-binary femme patients that we care for are Black African American. About 15% are Hispanic or Latinx, and a very small few are white identified. And it's a little bit different for the transmasculine patients that we have. There's a lot more a mix of diversity. So maybe about a third are identify as white, probably a little more than a third as Black African American, and then Hispanic patients as well. But we often have patients that travel from far distances that come to our clinic, and now that we have telemedicine since COVID, we've been able to really engage with patients from all over New Jersey. And I saw just a new patient just the other day from really the southernmost county in New Jersey via telemedicine.
Like Cape May, I think, is the very
Yeah.
tip.
Yeah.
Wow. So people are coming from all over New Jersey to your clinic.
Yep.
Is
Mhm.
that because there aren't a lot of these services available throughout New Jersey? You're only going to find them in the major urban areas like Essex County or Hudson County, or so if you
Yeah.
travel to certain parts of New Jersey, you're not going to find these services at all.
Yeah, I think that's true. Down in southern Jersey, just across the river in Philadelphia is the Mazzoni Center, which is a really well-known LGBTQ center that provides care to transgender folks, thousands, and it's really a very well-established clinical center, but it's difficult sometimes for, if you have New Jersey-based insurance, to even go into Pennsylvania there that you
Okay.
need. And I think there are also centers up further up in northern New Jersey, in Atlantic City area. What is the name of that town that Bruce Springsteen is from?
Asbury Park.
Asbury Park, yeah, exactly.
Yeah. Yeah. Yeah.
So there are definitely isolated centers. I think part of the problem also is that sometimes it's hard to find consistency within those centers. At least that's what the patients tell me. There used to be, a practice in Jersey City, which is actually where I live currently. But that provider left to go to Union or something, so there's always that element of like inconsistency as well. And then there are private practitioners who provide gender affirming hormone
There
care
are,
as well. Yeah.
but not probably not a lot, I would imagine.
And we don't actually really know, right? That is not something that's
Really?
well documented, but the impression that I get from my patients is that this is a very limited resource. Yeah.
So now I have a question. If I'm a transgender person, I come into the ER, say I've been assaulted or something terrible has happened to me. Are you consulted at all? Are you called in at all to treat that patient in any way? Are they connected to your clinic in any way in case they need follow-up care? Do you have any, kind of working relationship with the emergency room?
Not with the emergency room per se, but with the trauma service, the surgery trauma service, when patients are admitted, oftentimes they'll call me and ask me to come see a patient, particularly if a patient is going to be there for an extended period of time and is asking about continuation or initiation of hormone therapy. And oftentimes we'll, at the same time, have one of our patient navigators come and visit with the patient and connect them into care. Our system is very robust with respect to HIV referrals. We have a dedicated line, and we have a patient navigator that will go to the hospital and visit with the patient, get them connected into care. It's less formalized with respect to gender affirming care connection, and that's something that we want to try to work on. Because we want to make sure that patients are not, that their medications are not stopped at the time that they're admitted, that they get the care that's affirming, that they're getting the right treatment by the staff in the hospital, because we still have instances where patients may be misgendered while they're admitted to the hospital. And because right now it's kind of like, oh, if I'm the trauma surgeon, I know that Dr. DallaPiazza can come and see my patient, but that's only because I have that personal knowledge. Like there's no like formal consult service per se.
So now have your forms at the hospital been updated to be inclusive of people, LGBTQ people who may, the IDs may not reflect, may not match what their, what their gender expression is. In other words, their legal names, their legal IDs are different from the names that they want to use presently.
Yeah, thanks to Dr. Curtin, we've really worked with the IT department and the different registration areas in order to create a registration process that takes into account the sex assigned at birth and the gender identity and the name that the person has chosen. So we still have to have within the chart the legal name, because
Right.
it has to match whatever name is attached with their insurance or whatever payer that they have. But we've worked with Epic, which is our electronic medical record, to make sure that we've incorporated within the registration process the ability to add these. And when you look at the banner that's at the top of Epic, it has right along the banner the legal name, and then right next to that the chosen name, and then it also has a little section for gender identity.
Really?
It does, yeah. It doesn't have a section for pronouns per se, but it does have one for gender identity and for the chosen name.
Well, that's good to know, because I've been working with the Newark Police Department. One of the things we did was update their report form, because there was no, box or anything for people to be able to identify or check if their name was different from their legal name, or their pronouns, all of that type of stuff. So we were able to get that implemented recently. So it's good to know that Epic is a very widely used electronic medical record. So it's good to know that no matter where it is, they have the ability to do that.
Yeah.
So tell me what you love about your work.
There are lots of things I love about my work. I tell people I love being an HIV primary care provider. I love being an ID physician. I love, being a teacher, because I do a lot of teaching at the medical school as well. But there are a few things that are more gratifying than providing hormones for gender affirmation, and just gender affirmative care in general, because not everyone opts for hormones. It's something that is truly transformative. And I think we often take for granted how easy it is to just be in your skin when you're cisgender, and how easy it is to navigate the world with everyone clocking you as the gender that you've always, experienced, and taking that for granted. Because gender is a core element of our identity. It's how we navigate through the world, and how we're treated by others, and how we've been socialized to react to things, and socialized within our roles in society as mothers and sisters and aunts. And we have this very structured
Binary System, yes.
binary system. Exactly. And we just take for granted how core a part of our identity it is, just like age and race and ethnicity, and family heritage. These are all core parts of our identity. And so being able to help patients achieve their goals with respect to affirming that identity, that core part of you, it takes away so much of the burden that patients have to carry with them, and it helps them achieve other health goals too, right? So if you have that primary core part of you that is finally affirmed and able to navigate through the world as that identity, then you can also concentrate on things like stopping smoking and getting the appropriate vaccines at the appropriate times and getting the cancer screening that you're due for because of your age. So it's a way, it's definitely a way of not only thinking about meeting that core need, but also all these other health needs that everybody has, and taking that holistic approach to achieve really incredible health outcomes.
Well, it sounds like it's an empowering experience for folks, mentally, emotionally empowering to have that kind of support.
Right.
So that is wonderful. So before we got started, we were talking about COVID. And so I'd like you to talk a little bit about, the experience of COVID for you, and also some information that you were giving about the whole vaccine process and your involvement in that as well.
Right. Yeah. So, as an infectious diseases doctor, we, and as a division in general within the hospital, we've been intimately involved in the COVID response. And we were talking earlier about that first wave that we had back in April, and how all of our resources really had to be diverted to care for patients admitted to the hospital with severe COVID. At one point in April and May, we had over 300 patients admitted to University Hospital with severe COVID. So patients that required oxygen or mechanical ventilation and really kind of specialized care for the management of severe pneumonia. And there was a point in time too, where our medical school is right next to the county coroner's office, and they had so many deaths in Newark that they had to expand their morgue into our parking lot. And there were at least a dozen refrigerated trucks in order to manage the death toll that COVID was taking on our community. It was a surreal, unreal experience. At that time, we did have to shut down the clinic to
Yeah, I was
in-person.
about to say, how did that affect your clinic?
Yeah, we had to shut it down to in-person visits, and we tried to convert, the essential visits to telemedicine, which we were able actually to ramp up very quickly at the medical school, and that was really the role, how important the medical school was for getting that up and running for all of the physicians across departments. But so we were able to kind of stay open for telemedicine visits and COVID testing and urgent visits, but our patients didn't want to come in at that time. It was a really scary time. But now, so since June, we've been open to in-person visits, and we're doing about half in-person, half telemedicine. And we found that through telemedicine, we've been able to do a lot of outreach for patients who historically have a hard time getting into the clinic because of transportation issues or childcare issues, or because they live far away. So that's definitely been a plus. But we also have taken a role in research, and we're a site for the Moderna vaccine study. This is the one that they just reported on yesterday, that in the interim analysis, they found that the vaccine appears to be 94% effective for preventing COVID and 100% effective for preventing severe cases of COVID. So there were no cases of severe COVID in the vaccination group. This is a placebo-controlled trial. And this is really very important for our community. One of the things that's been really a problem with medical research in the past is that they have really failed to design clinical trials and to design the recruitment of clinical trials that would be inclusive of marginalized communities. And that's really the fault of the research community, not kind of thinking, kind of assuming that the norm is a cisgender white person, right? And
Mhm,
particular cisgender
mhm.
white man. And that's the norm, so we're going to design it for the norm and then kind of expect everyone to come to us. But if you do it that way, you're not really appropriately engaging with the communities that are most affected by infectious diseases, including COVID. So we were so honored and so happy to be able to offer this opportunity to our community and to make sure that marginalized communities disproportionately affected by COVID are
Okay.
represented in clinical trials, right? So not only is it a wonderful opportunity, but it's also, showing that we can do this. If we do it the right way, we can make sure that people are represented. So we've really made an effort to enroll exclusively people of color and older people in particular. So people over the age of 65. So, um, and we're just super excited about, the potential that these vaccines have for reducing community spread and really quashing this pandemic down to nothing. We may never be totally rid of COVID. It may be with us, for the long run, just like influenza and just like the cold virus and other things like that. But if we can get the majority of the population immunized and protected against COVID, then it has nowhere to go. It's not going to run rampant throughout our communities and
Right.
cause the devastation that it's causing.
So can you talk about the vaccine? We were talking about the two-step process and why that's necessary. So if you could inform us a little bit about how all that science works.
Right. So both the Pfizer vaccine and the Moderna vaccine, which are the two that have had this preliminary data coming out about their high effectiveness, are 2 doses. And they're both the same type of vaccine, although they're not exactly the same. They're a type of vaccine that's called mRNA, which is not a type of vaccine that has been, not like the vaccines that we know, like the flu vaccine. These are different. What these do is they actually stimulate the person's body to make one particular little protein of the virus called the spike protein. So it's just one little tiny component that your own body is making. And then your own body making this component of the virus causes your immune system to react to this little protein as if it's actually seen the virus itself. And that response is then what protects you in the future from getting infected or from getting severely ill if you are exposed to COVID. And so it's a novel type of vaccine therapy, one that's so far proven to be quite safe, and one that so far has been proven to be highly effective. In the early studies, they found that you needed 2 doses in order for the body to produce enough neutralizing antibody in the blood. And so that's why both of them are 2 doses. But
And those two doses are taken at what sequence? So you take the first dose, how many days later do you take the second dose?
I'm not sure about the Pfizer vaccine, but the Moderna vaccine is within a month. They're 2 doses, yeah. And I think that what's also really important about these trials is these trials are not over, right? So they're going to be continuing and ongoing. And in fact, Moderna is trying to think of a way to offer the vaccine to people already enrolled in the trial who got placebo, in order to make sure that they also benefit from their participation in the clinical trial. But they're going to be following participants in this trial for many weeks and months and even years, to really make sure that they follow out over the long term for safety. And they also want to know how long this protection lasts. So these are
Because
questions.
this is all new, right?
Exactly. So
What do you attribute your success to for being able to enroll minority people into the trials?
Well, this is not exactly my area of expertise. I'm one of the investigators in the clinical trial. Dr. Swaminathan is the principal investigator for the trial at the Newark site. And our colleagues, Jameer and Travis, are really have been instrumental in our research program because they have really taken charge of the community outreach and the community engagement. And you know, before we had Jameer and Travis and the rest of our research study staff that are really engaged with community engagement, there was no conversation, and there was no understanding kind of between the research teams and the community at large. But they've really transformed our program by incorporating a lot more community engagement and tackling these difficult topics like vaccine hesitation and the distrust within the community about clinical trials and about the medical establishment in general. You know, basically engaging with those types of conversations. And then we, again, at University Hospital, we have incredible allies. Dr. El Nahal, who is the CEO of the hospital, Dr. Chris Purnell, who is the health equity officer, have been very instrumental in helping to really engage with the hospital community and the staff, as well as the larger community in Newark and our research program, and kind of pulling it all together so that there's a lot of dialogue.
Will you continue to rely on telemedicine even, you know, past COVID, since you said it seems to have made your services more accessible to people, and I guess people are probably more compliant, you're able to reach them, you cut out some of the issues that the barriers like transportation. And so will you continue to rely on telehealth post-COVID? Because there will be a post-COVID.
Oh yeah, definitely. Oh, absolutely. Yeah. I mean, we've reaped so many benefits from being able to engage in telehealth. And we actually had a plan to develop a telehealth program before COVID hit. And we're hitting all these barriers. What about reimbursement? And what about the hospital? And there's no structure in Epic, and you know, all these barriers that we had to try to like trudge through. And then COVID hit, and when there was a will, there was a way, and those barriers, they went away. And part of it is also that the barriers on the part of CMS and the Department of Health and Human Services also went away, because they had very stringent criteria by which a visit could qualify as a telemedicine visit. And those were relaxed under COVID as a necessary precaution for people to continue getting their care, even if they couldn't come into their doctor's office.
Yes, that is one of the good things that came out of this.
Yeah.
You know, the fact that not only is the technology there to do it, but now the insurers are going to cover it, which
Right.
makes it even more accessible to more people. From my own experience, I was telling you about the sister I care for, most of her visits at this point are telemedicine.
Yeah.
And so it's fascinating to see this 96-year-old woman talking into my cell phone, and fascinated after every visit, you know, that her doctor is right there on the screen, and he can look at her body and examine her legs and so many other things, and it keeps her safe. You know, she's not in the waiting room. I'm not having to take her into an office. And you know, it's been very helpful for managing her care. So I really appreciate telehealth myself.
Yeah.
So doctor, how would you like to wrap up? Can you tell us how you can access your services, the phone number, location, etc.?
Yeah, sure. Yeah, our clinic is at the D level of the Ambulatory Care Center, 140 Bergen Street in Newark, associated with University Hospital, as I mentioned before. And our the number to our front desk is 973-972-5111. And again, as I mentioned, Dr. Finkel, Dr. DallaPiazza, we are primarily the providers that do gender affirming hormone therapy. I had mentioned Dr. Bensianoff. She is part of the Division of Adolescent and Young Adult Medicine. She's at 90 Bergen. I don't have her phone number off the top of my head.
Okay.
But if anyone Googles DAM, Rutgers, New Jersey Medical School, the contact number would be there. And then we also do have a surgical program, Dr. Einstein and Dr. Marcus in OBGYN, and Dr. Edward Lee in plastic surgery. Dr. Lee does chest masculinization and feminization, and Dr. Marcus and Dr. Einstein primarily do hysterectomy, oophorectomy, and other gender affirming therapies for transmasculine folks.
Do your patients do they interact with their families? Do you see a lot of support there for their families, or they have a tendency to be kind of estranged in those relationships?
So it depends. And, it really depends. Sometimes it depends also on the age of the patient.
Mhm,
Oftentimes,
mhm,
younger patients may have more familial support than older patients. So I have some patients over the age of 60 who are transitioning at a very late age in life, over 50, over 60. It's very difficult at that stage in life because of the sort of rigid, systems that we're brought up in, and a whole lifetime with the lived experience in one gender, with relationships and children and jobs and things like that. Our younger patients, though, tend to generally have, not always, but generally may be more likely to have some familial support. And oftentimes, my younger patients may come to the office or be on their telemedicine visit with their parents. Um, some of my patients also bring in siblings with them. Sometimes the siblings are supportive, sometimes they're not.
mm.
And but it's really wonderful to see a growing acceptance, familial acceptance, because familial rejection is a tragic thing to have to experience.
Yeah, for us as a Newark LGBT community center, that's one of the things that we see when people used to come into the trans people would come into the center. We would often hear these stories about the problems that they have with family, and we always felt like people who had better connections to their family were people who were mentally healthier, emotionally healthier. We used to have people come in who would just come in to change their clothes and go home because they and these were, and that occurred mostly in an older population, like you said.
Yeah.
Younger people have a tendency to be more, this is me, this is who I am, take it or leave it. While a lot of older people who were transitioning later on have, like you said, had this lived experience as they're cisgender, and they have families and husbands or wives and children and grandchildren. And so there's this complex family relationship that has to be navigated as they're going through transition. And so that was something we would experience at the center. Doctor, I want to thank you. This has been a wonderful conversation. We will have to do this again.
Yeah, thank you so much, Beatrice. I really, really appreciate it.
Yeah, and I'll make sure that I get the video out to you as well. And I look forward to having a follow-up conversation with you sometime in the near future.
Thank you so much. Have a good evening.
All right, thank you, doctor.
Bye-bye.
Bye. Bye-bye.